The objectives for this lecture are listed here: a little bit of embryology, a little bit of histology, some physiology, and bloody nose. And so what's the name for a bloody nose? Epistaxis, okay. So the thing about the ophthalmoscope and the fundoscopic exam is coming. So I hope you're getting prepared and practiced up on that. It's coming. Morning. Okay? If you don't know what I'm talking about, go back about 2 months ago when I told you you better know how to do it, because it's coming. Okay? Embryology. The adrenal glands, or suprarenal glands, they begin at the same place in the embryo where you're going to find the kidney development. In other words, it's retroperitoneal, it's on the posterior wall, and there's a collection of cells that defined as a little nodule along that urogenital ridge, beginning just a couple of weeks after folding. So it says up here 6 weeks. Remember, that's only a couple of weeks after folding. So the definitive adrenal gland, its location is recognized pretty doggone early. Now, it says here a couple of different things that you see here, where it says fetal cortex versus the primordium of the permanent cortex. This is what you recognize early, all right? It's going to be a collection of cells that are not going to develop into the adrenal gland. That's the location. They're sort of reserving the spot. From there, you get differentiation of some of these cells into the primordium here. This is where you're going to start getting the different layers, the layering of the cortex right here. Now know that the adrenal cortex and the adrenal medulla originate from two different places. Right now I'm just talking about the cortex. This little ball right here represents the medulla. It actually arises from the back and migrates into the cortex that's wrapping around it. So embryologically, they're two separate structures. This is mesoderm. That's going to be ectoderm. Mesoderm versus ectoderm. All right, so as you start developing as a little fetus, the size of the adrenal cortex grows considerably. And it starts parcellating out into two distinct layers. The outer glomerulosa layer, and then the zona fasciculata. So as you follow these things through here, you can see the different layers. There's the fetal cortex, the primordial cortex. So these layers are developing from that primordial cortex there. First the glomerulosa, next the fasciculata. The reticularis, which produces sex hormones, primarily, well, exclusively testosterone, it doesn't even show up until the kid is a few years old. So at birth, you not only have this great big, huge cortex, adrenal gland, it only has two layers, plus the medulla. Okay? Right after birth, it starts, you have apoptosis, so the size of the thing dramatically decreases, and then it takes a few years, it takes some time before it eventually gets back up to its normal proportion versus the rest of your body. The thing you need to keep, one of the things you need to keep in mind in terms of development, and you'll see this later on, is that of the three layers of the cortex, by far the thickest one is going to be, as it says here, the fasciculata. Most of the cortex is fasciculata. All right, where it says here, the medulla from neural crest cells, these are the neural crest cells here. Here's the developing spinal cord there. The epithelial cells that are out here migrate into the developing embryo and will distribute as the different types of ganglion cells of the nervous system. Here you have the dorsal, these collection of cells are going to become the dorsal root ganglia. The one that's not labeled right here, that collection of cells are going to become the sympathetic chain ganglia. You've got cells that distribute within the gut tube. They're going to become the parasympathetic postganglionics. And then you have cells right here and that along that urogenital ridge that are going to develop into the adrenal medulla. These are all ectodermally derived tissues. In this illustration right here, the only thing I want to show is anatomically where you're going to find the adrenal glands. You know that they sit on top of the kidneys, but what you also need to know, though, is that they are within the renal fascia. You can see the outline of the renal fascia. There's the suprarenal gland. They're within the renal fascia. Remember back in the 100 years ago in anatomy, we talked about primary retroperitoneal versus secondary retroperitoneal. The adrenal glands, like the kidneys, or like the entire urogenital system, is primary retroperitoneal. It never was in the peritoneal cavity, never will be. It developed outside. So you can reach the adrenal glands going back through here without ever having to penetrate the peritoneal cavity. This is something that I want you to ponder on when you are in the pondering mood, because I have been looking at this thing for a week now, and I still can't figure it out, and I have a PhD in anatomy. This thing is the inferior vena cava. That's what it's labeled. We know that's the inferior vena cava. I think what they're showing here is that this is cut and moved up, because that's the diaphragm. There's the aorta going through the diaphragm. There's the esophagus going down. What the hell is that? Other than they cut it and they lifted it up so that you could see this area, right? I got that. What I cannot figure out is what those three holes are. If you can figure out what those three holes are, email me and the class, because I cannot figure it out. Okay? That's all I wanted to show you. It's inside the renal fascia, and I don't know what those three holes are. All right. The nervous system, as it applies to the adrenal medulla, is, you know, when you're talking about the autonomic nervous system, and you're talking about the parasympathetic system, you've got preganglionics and you've got postganglionics. Both of these use acetylcholine as a neurotransmitter. When you're talking about the sympathetic nervous system, you've got preganglionics and you've got postganglionics. The preganglionic still uses acetylcholine as a neurotransmitter. The postganglionic uses norepinephrine. The adrenal medulla is acting as the postganglionic sympathetic neuron. In that the splanchnic nerves, remember the thoracic splanchnic nerves, stay splanchnic, remember, is predominant preganglionic. Stays preganglionic. You see right here where it's synapsing on the postganglionics, going to different things. And then that is continuing as preganglionic to go to the adrenal medulla. The only thing that's different here about this system is that this is acetylcholine, if this is the adrenal medulla, the adrenal medulla releases epinephrine and norepinephrine at a ratio of 40% to 20%, 80% to 20%. So the adrenal medullary cells, they're also called chromaffin cells, chromaffin, like chrome on a car, because if you put chromaffins, chrome salts on it, they will stain brown, so you can identify them. It's called a chromaffin reaction. If you look at those cells in here that do not have axons or dendrites, they're just cells, 80% of those cells will secrete epinephrine and only 20% norepinephrine. So when you're trying to compare and contrast the postganglionic sympathetics versus the adrenal medulla, it has to do with their predominant neurotransmitter. Postganglionic sympathetics never secrete epinephrine. It's always norepinephrine. This is a thing, in case the Jeopardy thing. When you look at receptors, and you're talking about things that block or facilitate these receptors, epinephrine is epinephrine. You give somebody adrenaline, epinephrine, it activates everything. You take adrenergic receptors and you can divide them into beta 1, beta 2, alpha 1, alpha 2, depending on where they are, right? The trachea versus the heart versus, you know that. Acetylcholine, to activate it, it only requires acetylcholine, regardless of where you're activating it here, 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 or here. You give somebody acetylcholine, it activates them all. But if you want to block acetylcholine, it actually requires one of two different agents. One is nicotine, the other is muscarine. Has Cassie, has she gone over this? No? Okay. This right here, that, if you want to block that, you want to use muscarine. If you want to block any of these other sites, this one, or that one, you have to use nicotine. So this is the difference between a nicotinic receptor and a muscarinic receptor. And the reason I point this out has nothing to do with the sympathetic, the adrenal gland. Atropine. Atropine. You know atropine, you know the drug atropine? Everybody not know what atropine is? Atropine can be used to increase the heart rate. Bradycardia, that's what you treat bradycardia with, is atropine. When you go get your eyes dilated, they put a drop of atropine in there. What is atropine? Atropine is an anti-muscarinic agent. It blocks muscarine. So if I block that, if I put a drop of that in your eye, what's going to happen to your eye?
Dilate.
You can no longer constrict it, it will dilate. If I give you atropine on your heart, what does the parasympathetics do to the heart? They slow it down. If I block that, what will the sympathetics do? They're unopposed, so your heart rate will go up. That's what atropine is. Okay? Again, it has absolutely nothing to do with what we're talking about today. But you need to know that. Okay? All right, here's something else you need to know. In the workup of pheochromocytoma, I'm going to talk about this later on, but I wanted to put this slide in here now because it relates to this right here. This is the organization of the sympathetic nervous system, right? And you get all of these pre-aortic ganglia that are going to synapse. That's what all these pre-aortic ganglia are. If you're working up a pheo, which is most often a tumor of the adrenal medulla, if you have a tumor of that, what do you think this is going to do to your heart rate, blood pressure? What does that do to your heart rate, blood pressure? It's going to increase your heart rate, increase your blood pressure. Right? You'll also sweat like a pig because these are the cells that end in your sweat glands. Right? So if you're dumping out all of this adrenaline, you're going to sweat. So you would get a CAT scan of the abdomen to see if there's a tumor of the adrenal medulla, right? You will always get back, if you put on your thing the reason why you're getting that CAT scan, you'll always get back a statement regarding the organ of Zuckerkandl. The organ of Zuckerkandl is a collection of, if anybody speaks German, I appreciate knowing what the real pronunciation of this dead guy's name is. But right there around the inferior mesenteric artery, there's a collection of adrenergic neurons. So if you suspect a pheo and you get a CT scan and the adrenals come back clean, you want to know, is the tumor here? So the radiologist will always make a comment that the pre-aortic ganglia, specifically the organ of Zuckerkandl, appears normal in size. Okay, that's a way outside point, but I've seen it on X-ray reports, CT reports, and you need to know what that is. It's one of those zebra things that'll jump up to bite you if you miss it. Okay, so let's look at the adrenal cortex. You can see in this stained slide here, all of this right here is the adrenal medulla. So here are the three layers. The glomerulosa, the fasciculata, and the reticularis. First of all, the glomerulosa, the cells are arranged concentrically. They're just kind of like little cul-de-sacs. It's not an endocrine. They don't secrete into a duct. They're just arranged sort of like, I don't know, concentric rings. Versus the fasciculata, the cells are arranged in vertical rows. And you can see this, you can sort of see the vertical rows here. You can probably see it better here, yeah. Vertical rows there. And in the reticularis layer, it's thicker than the glomerulosa, but nowhere near as thick as the fasciculata. Those cells are also arranged sort of clusters, groups, clumps, not in a structured vertical area. Now the thing about the capillaries that are between these things here, they're highly fenestrated. They're highly fenestrated. If you go back up to the top, the glomerulosa, those cells secrete aldosterone under the influence of angiotensin II and ACTH from the pituitary. Anterior or posterior? Anterior pituitary, ACTH. The fasciculata is going to be secreting cortisol, glucocorticoids. Glucocorticoids have an effect on blood sugar. That's why it's sugar right here. And they're under the influence of ACTH alone. As is the reticularis layer, it's going to be secreting testosterone products, also under ACTH. The fact that you have such a highly vascularized cortex means that you're going to take those hormones, these lipid, cholesterol-based hormones, and you're going to dump them into the adrenal medulla. Once you're in the adrenal medulla, the capillaries become sinusoids. In other words, they have great big gaps for movement of fluid. If we look at the adrenal medulla, here we go. We're going to start right here. There's our preganglionic sympathetic axon releasing acetylcholine as its neurotransmitter. Causes the activation of the cell, the calcium jumps in, you get release of granules, and norepinephrine predominantly dumps out into those large sinusoids. The other thing you need to keep in mind is, look right here, enzymatic activity induced by glucocorticoids coming down from the adrenal cortex. Tyrosine is the amino acid that will yield those two neurotransmitters. Tyrosine is converted along this pathway by tyrosine hydroxylase, which says up at the top, the rate limiting step, into dopa, then dopamine, then norepi, then epi. That's the pathway. Serotonin is also an amine, but it's not related to this pathway. When you're dealing with things like depression, dopamine and serotonin are your big neurotransmitters you're going after. Realize there are two different pathways here. Okay. All right. There are a couple of enzymes here. PNNT is a useful one to know. And dopamine beta hydroxylase is a useful one to know. Okay. Going back to this, we see our pathway right here. And at the ultrastructure level, the epinephrine and norepinephrine form dense core vesicles. These little black vesicles are all the adrenaline-containing vesicles. There are thousands of them in a cell. There's another component, there's another protein that's co-packaged with norepi and epi. That's called, well, they go by several different names. Chromogranins is one name. You may hear it referred to just as granins, or chromogranin A versus chromogranin B. A couple of points I want to make about that is that chromogranins are proteins that have a paracrine function. Once they're released, along with the epi and norepi, they influence the release of more or less hormone or adrenaline from the adrenal medulla. The other thing is that if you have a pheochromocytoma and you've taken out the adrenal gland on that side, and you want to monitor whether or not it comes back, what you get is you can't measure serum norepinephrine. What you measure is chromogranin A. You know, just like you do CA-125 for the ovary, or HCG for testicular cancer. Chromogranin A is what you measure for adrenal medullary tumors. All right. Any questions about anything here?
I have a question. The enzymes that you asked us to know on the tyrosine chain, do you just want us to know what their converting, or is there something else?
Yeah, because you need to know, this is a pathway you need to know. Because a lot of drugs that you are going to be using to treat autonomic dysfunction or blood pressure or mental health disease affect these enzymes. So knowing this pathway is, it's a simple pathway. It's something I just commit to memory. Also, Parkinson's disease, Alzheimer's disease is based on dopamine. Now, how do you get rid of adrenaline in the body? There are two enzymes that break down norepinephrine and epinephrine. That's monoamine oxidase and COMT, catecholomethyltransferase. These things bring epinephrine and norepinephrine down into metanephrines and normetanephrines. Those are further acted upon by the same enzymes into what is called vanillimandelic acid. This right here is vanillimandelic acid. Dopamine has a similar pathway into homovanillic acid, to be distinguished from milli-vanilli. You guys, do you remember this? You don't remember this group? You don't remember this group? The whole thing, the big smackdown on this guy, these two guys? I think it was in the 90s. Was it the 90s?
I remember that.
You remember? Come on, you've got it. These guys were big hip-hop, or no, probably predated hip-hop, more like pop rock. I mean, they were big, they were big, having concerts all over the place. Turns out they were lip-syncing everything. And they had won all these Grammys and stuff like that, and then they found out they were lip-syncing, and then they fell off the face of the earth. But I mean, there you go. Also, not to be confused with my wife's stinking cat, whose name is Millie. I tried to get a picture of that damn cat yesterday to put on this slide, but I couldn't get it to hold still. So if you're investigating a medullary tumor, adrenal medullary tumor, then what you're going to measure will be urinary metanephrines, normetanephrines, VMA, and homovanillic acid. Just shorten that to VMA. And the way you do this is not with just one urine sample. You collect urine over 24 hours, and you measure these things over a 24-hour period, because what happens with adrenal medullary tumors is they pulse. They'll pour out a ton of norepi and epi, and then they'll go quiet for a while, and then they'll do it again. And then so that's why when somebody comes in and with hypertension, and it's serious hypertension, not like 140 over 95, it'll be 190 over 120. An hour later, it's normal. 4 hours later, it's off the chart again. So these people, they do this with adrenal tumors, adrenal medullary tumors. And that's one thing that when you're working up hypertension, you want to make sure that that elevated blood pressure is consistent versus cyclical. So that's why you get a VMA, mostly just VMA and metanephrines and normetanephrines. Because again, homovanillic acid is measuring dopamine, which is not being released by an adrenal medullary tumor. The vascular supply of the adrenal glands is massive. It comes from 3 different sources that I'm sure you remember from anatomy. You've got many branches off the inferior phrenic. You've got a branch off of the aorta, and you've got a branch off of the renal artery on both sides. You have one suprarenal vein, a large suprarenal vein that drains the whole shooting match. on the left side, it drains into the left renal vein, just like the testicular ovarian vein. On the right side, it drains directly into the inferior vena cava.
Those are the hepatic veins.
Hepatic veins. The No, so I was thinking, okay, the superior mesenteric, inferior mesenteric, all the gut veins are going to be in the portal vein. The venous drainage from the liver is the hepatic veins on the top of the liver. I mean, I guess it could be that, but I don't.
When I looked up other pictures where it had it like transected like that and it was
They call it
across,
hepatic
it was
veins?
hepatic veins.
Okay, I'll buy that, I'll buy that. All right, good job. I just couldn't figure it out. Why do they have this gap here so anyway, thank you, Samantha. All right. So you know how you walk around the door, if you walk around the door like this, by the way, isn't it cool in here? You walk around the door and there's a big rattlesnake sitting right there. And all of a sudden you go, ah, and your heart starts racing, right? What makes it do that? Well, it's probably this being dumped out into the circulation. The question is, why is it so instant? Why is it instant? How many heartbeats do you think it takes to get blood, venous blood, from here to the heart? Probably just one, maybe two. Because that's where this blood is going. It's not going to the liver, it's going directly to the heart. That's my best guess of what happens. Okay. Now, the arterial side is different. So there are three different arteries. The ones off the phrenic and the ones off the aorta form this network of arterioles right here, and capillaries once they get inside. The ones off of the renal are here. These are called medullary arteries. They enter through the capsule and go straight through the cortex without fenestra. They go straight to the medulla. They don't have anything to do with the cortex. They go straight to the medulla. So this is like the blood supply of the medulla is there. These have millions of fenestra and are the reason for the hormonal exchange. They all get together down in the medulla to form these large sinuses that will go to form the suprarenal vein. And this is what it looks like here. You've got the medullary arteries right there versus the ones that are picking up the mineralocorticoids and the cortisol and sex hormones being the small ones. This is a pheochromocytoma. You can see the yellow is the adrenal cortex, and you've got this large tumor sitting right there. Most pheos are benign in terms of not malignant potential. They can still kill you, but as far as malignant, they don't spread. And most of them are sporadic. It just happens. Mostly in middle-aged people, mostly guys. About 10% of, and mostly one side or the other, not bilateral. Versus a syndrome called multiple endocrine neoplasia, the MIN syndromes. And there's a MIN1 and a MIN2. And they have to do with proto-oncogene mutations that you see here. These types of tumors are usually bilateral. The thing about distinguishing, though, a sporadic pheo versus a MIN syndrome pheo has to do not so much with the adrenal medulla side, though. It has to do with the thyroid. Because this medullary carcinoma of the thyroid that you see in MIN2 syndromes is a highly aggressive cancer. That's the malignant potential in MIN syndromes. The clinical course of unchecked pheo or MIN syndrome here, aside from the thyroid, would be obvious hypertension leading to stroke, and if untreated, leading to failure and pulmonary edema. And you're not going to see anybody getting to this far without being treated. And of course, the treatment is removal if it's a unilateral lesion. Treating them with beta blockers, all sorts of antihypertensives to get their pressure down if it's a MIN syndrome. You can't go removing both adrenal glands. All right. Here's a little bit about the physiology. We've got the glomerulosa up there is going to be secreting aldosterone, you know that, aldosterone, under the angiotensin II and ACTH. The other two are ACTH, that's the stimulating hormone, and they're going to be dumping out glucocorticoids versus sex hormones. Now here's the thing you need to know about the transition. The transition between the glomerulosa and the fasciculata is absolute. These secrete aldosterone, the cell right below it secretes cortisol. No two ways around it. They can't go back and forth. However, when you get down between the junction between the fasciculata and reticularis, it's not quite so, it's not defined. There's a little bit of transition here. Some of the lower part of the fascicularis can be secreting sex hormones. And you can get glucocorticoids coming out of the reticularis. So it's not quite like you see it above. That's why if you see right here, they kind of mix these up on the lower end, but not up here. If you look at the cells, regardless of which layer, GFR, they all look at the electron microscopic level very similar. All of those hormones, aldosterone, glucocorticoids, sex hormones, arise from cholesterol. They're all related to LDL specifically. So since they're a fat-related product, the cell looks nothing like a protein synthesizing cell. It has minimal RER. The only RER it would have would be enough to make its own intracellular proteins. It's not transporting any protein. So the cellular organelles that you'll see in fat-producing cells, or cells that synthesize fat-related hormones, are one, lipid droplets. And you see up here in this thing, all of these droplets of cholesterol that the cell has acquired. the endoplasmic reticulum is dilated and without any ribosomes attached to it. So it's smooth endoplasmic reticulum. All of that stuff right here, all these little circles, all that stuff is smooth SER. And the mitochondria, the cristae, are tubular. If you look at the mitochondria of a protein synthesizing cell, the cristae look like that. But on a one of these cells, it's tubular. Within the membranes of the tubules are the enzymes for production of these hormones. As a matter of fact, those enzymes are located in two places. One is they're located on the tubular cristae of the mitochondria, and the second place is on the SER. This is the pathway for hormone production. Starts out as cholesterol, then you make pregnenolone. Over here there's progesterone. Now you have, if you're going to make aldosterone, you come down through this pathway using 21-hydroxylase. That's the enzyme that starts this process, on down through here to make aldosterone. Only the glomerulosa cells have 21, sorry, not 21-hydroxylase, have aldosterone synthase. Only the adrenal glomerulosa cells have aldosterone synthase. Now the branch point here takes you down through this pathway to give you cortisol, or this pathway using 1720 lyase to give you androstenedione, which is a precursor to testosterone. Testosterone is aromatized in certain tissues, like fat, the ovaries, or the follicular cells around follicles, into estrogen, an estrogen product. There are a whole bunch of different estrogens: estradiol, estriol, estrone. All of these estrogen-related products have a similar function. They're all derived from testosterone. Okay. So if you read these little blocks down here, the zona glomerulosa lacks the enzyme 17-alpha-hydroxylase and 1720 lyase. Well, 17-alpha-hydroxylase is here and there. And 1720 lyase is here. So these cells cannot make cortisol or androstenedione. Similarly, these cells lack aldosterone synthase. They cannot make aldosterone. All right. Now, if you're more of a visual learner, this is the easiest way I can appreciate this pathway. And you need to know these enzymes and what they do that I've mentioned. There's another way to look at them, and that's this way. You can start with cholesterol and go down through here to the aldosterone versus cortisol versus testosterone. If you, that's kind of a neat pathway schematic there. If you're more of a visual learner. Right? So, what you have here is you have LDL cholesterol gets into the cell, and then it's shuttled between the smooth endoplasmic reticulum and the mitochondria back and forth depending on where the enzyme is. And for all of the three different layers of cells here, the only thing I want you to take home from this is that there is a shuttling back and forth to produce the end product. That's all you need to appreciate. Now, the other thing I want you to see about this is this little box right here, congenital adrenal hyperplasia. Well, in congenital adrenal hyperplasia, the enzyme defect that they wind up with, it's a inherited disorder, there's a defect in a gene that produces the enzyme 21-hydroxylase. If you go back to this right here, where's 21-hydroxylase? There it is there, and there it is there. So, if you're not making 21-hydroxylase, what's going to happen? You're not going to have aldosterone. If you don't have aldosterone, what does aldosterone do? Cause the reabsorption of sodium with water raises blood pressure. If you don't have aldosterone, you're going to have decreased sodium, you're going to have hyponatremia with hypotension. Also, since you can't make this and you can't make this, cortisol, and I'll show you in just a minute, is a positive or negative feedback on the hypothalamus and pituitary. If you're not making it, what do you think the pituitary is doing? Dumping out more ACTH. What does ACTH stimulate? This, and this. So if you can't make that at all, you can't really make that, you're going to be making a ton of that. Everybody follow me? All right. So read that little thing right there, and it all makes sense. Okay, so some points to consider here. Cortisol and testosterone, once they are secreted, they are bound to carrier proteins in the circulation. Free cortisol, though, is what provides the negative feedback. The quantity of free cortisol is what provides the negative feedback to both the pituitary, anterior pituitary, and hypothalamus. Oh, this is something I think I may have told you before while we're here. You know, when you're asleep in the morning, and it's 4 o'clock in the morning, and you know your alarm's going to go off at 6, your brain knows that. You know, you've decided, I got to get up at 6 tomorrow, right? So your brain knows you got to get up at 6. Well, when you get up at 6, you need to be ready to go. Your body needs to be ready to go. You can't be dragging ass around till noon. You got to be ready to go, right? So what happens is there is a place in the nervous system, and we'll go over this place when we do the nervous system in a couple of weeks, that starts sending out signals that causes the release from the hypothalamus of CRH, corticotropin releasing hormone. CRH, factor, CRF. CRH, CRF. That induces the release of ACTH by the anterior pituitary that occurs at around 5:45 a.m. The ACTH is going to the adrenal medulla. It's going to cause a production of cortisol. So you're going to have a spike in cortisol at 5:48. What does cortisol do to the adrenal medulla? Right there. The adrenal medulla dumps out norepinephrine and epinephrine that causes your get up and go. It raises your blood pressure, increases your pulse, so you're ready to go. It also constricts blood vessels, which is why half of all heart attacks occur between the hours of 6 a.m. and noon. It has to do with this cortisol spike. Okay, go take a break and then we'll come back. We'll sit right there, it doesn't matter.